Welcome to the Basic Obstetric Ultrasound Training Course for Healthcare Providers. Ultrasound plays an important role in identifying pregnancy-related conditions that put the mother or fetus at risk during delivery. In most low-income countries, there is a shortage of people experienced in performing pregnancy ultrasound. This course was created to train healthcare workers to perform basic pregnancy ultrasound in parts of the world where formal training is not available. The videos, as well as other educational materials, available at tinyurl.com/UW-ultrasound, are designed to be used in a 2-week ultrasound course. The hands-on sessions in the trainer's guide are an essential component of this course and must be supervised by an experienced ultrasound practitioner. This is not a comprehensive pregnancy ultrasound course and does not result in an official certification or diploma. After you finish the course and pass the written and practical tests, we strongly recommend you have at least 40 hours of scanning experience with clinical mentoring before you undertake unsupervised scanning. My name is Dr. Christina Adams Waldorf, and I will be narrating this 15th video in our Pregnancy Ultrasound series. This video will focus on multiple pregnancy. Please visit our website for access to all of our training and video materials. There are 3 main skills you will learn in this lesson. You will learn how to identify dizygotic and monozygotic twins on ultrasound, identify complications that can result in high-risk birth, and to properly refer patients with multiple gestation to the hospital. There are 3 main terms that you will learn in this lesson: dizygotic twins, monozygotic twins, and twin-to-twin transfusion. Dizygotic twins are twins that develop from 2 separate eggs. These twins are not identical and are sometimes called fraternal twins. Monozygotic twins are twins that develop from 1 egg and are identical. Twin-to-twin transfusion is a condition where blood from one twin is transferred to the other, causing abnormal growth of both twins. About 1 to 2% of pregnancies result in 2 or more fetuses, which we refer to as multiple gestation. Complications in these pregnancies are increased both for the fetuses and the mother. Because of these possible complications, we need to follow pregnancies with multiple gestation closely. Some of these complications can include preterm birth and low birth weight, which puts the baby at a higher risk for dying and having health problems such as mental retardation, breathing, vision, and hearing problems. Fetal death. This is generally uncommon, but more common with multiple gestation than when there is only 1 fetus. Placental abruption. This is a condition in which the placenta prematurely separates from the uterus and causes bleeding. It can occur in the 2nd or 3rd trimester or after the delivery of the first baby. Obstructed labor. This is a condition in which one or both twins can become stuck in the birth canal during delivery. Multiple gestations should be delivered in the hospital in case cesarean section is necessary. In addition, there is a higher risk of developing gestational diabetes and preeclampsia, which can affect the health of the fetuses and mother. Ultrasound can identify all patients with multiple gestation. This is why the robust scan is so important. Without ultrasound, many multiple gestations are unsuspected at delivery. Because of the higher risks to the fetuses and mother, multiple gestations need close monitoring. The timing of the follow-up antenatal care visits and additional ultrasounds should be decided by the obstetrician at the referral hospital. All mothers with a multiple gestation should deliver at the hospital in case a cesarean section will be needed. Patients should not wait until their due date to go to the hospital. They should go at a date decided by the obstetrician at the referral hospital. In a normal menstrual cycle, the ovary releases only 1 egg. However, the ovary will sometimes release 2 eggs instead of 1, and if fertilized by sperm, each can develop into a separate fetus inside its own gestational sac and with its own placenta. This is what we refer to as a dizygotic pregnancy, which formed from 2 embryos. This is the most common way twins develop. 7 out of every 10 twin pregnancies form in this way. This illustration shows dizygotic twins that developed from 2 embryos. Each twin has its own gestational sac and separate placenta. We call twins with 2 placentas and 2 gestational sacs dichorionic, diamniotic. Dichorionic means 2 placentas, and diamniotic means 2 amniotic sacs. Often these twins are referred to as di-di twins for short. On ultrasound, you can often see a thick membrane separating di-di twins, especially if the ultrasound is done early in the first trimester. In less common situations, one egg is fertilized by a single sperm, then splits into 2 embryos, which makes 2 identical fetuses. The number of gestational sacs and placentas is determined by the timing of embryo split after fertilization. 3 out of every 10 twin pregnancies form in this way. If division of the embryo occurred in the first 3 days after fertilization, each twin will have its own gestational sac and placenta. These twins are also called dichorionic, diamniotic, or di-di, but in this case they are identical because they developed from a single embryo. In both dizygotic twins and monozygotic twins that split very early after fertilization, you will see the same features on ultrasound. You should see 2 separate gestational sacs, each with a fetus in the early first trimester. Later in the first trimester, you will see a thick membrane between the 2 sacs. This membrane may be difficult to see later in pregnancy. You may see 2 placentas, or the 2 placentas may look like one very large placenta in the second and third trimesters. This is a typical ultrasound image of a dichorionic, diamniotic, or di-di twin pregnancy. What can you see in this image? Please pause the video now to encourage a volunteer to identify structures in the image. Here you see 2 widely separated gestational sacs. Here are 2 images that are also typical of a di-di twin pregnancy at 10 weeks. Please ask a volunteer to identify what they see in the left image and pause the video. Here we have labeled the 2 gestational sacs, 2 fetal poles, and placenta that can be seen in this image. Note that the dividing membrane looks thick in this image, which is typical in a di-di twin pregnancy. There are 2 placentas in this pregnancy, but only one of the placentas can be seen in this image. What are the structures noted by stars in the right image? What is the large anechoic structure to the right of the twin pregnancy in the right image? The answer is that the stars marked 2 placentas that can be seen in the right image. The anechoic structure to the right is the maternal bladder. In this image, the dividing membrane does not appear as thick as on the left, but additional images are likely to show a thicker dividing membrane. What happens when monozygotic twins divide later than 3 days after fertilization? If embryo division occurs between days 4 through 8, the embryo will split into 2 identical fetuses, but this time only a single placenta will form with 2 amniotic sacs. This is called a monochorionic, diamniotic twin pregnancy. Monochorionic means that there's only 1 placenta for both twins, and diamniotic means that there are 2 amniotic sacs. On ultrasound, you can sometimes see a very thin membrane separating the twins. This membrane will appear thinner than what is usually seen in di-di twin pregnancies. Very rarely, embryo division occurs late, between 8 and 13 days after fertilization. At this time, only a single placenta and amniotic sac will form, which means that both twins are contained within the same sac. This is called a monochorionic, monoamniotic twin pregnancy to indicate that there is only 1 placenta and 1 amniotic sac. Fetal death is more common in this type of twins from umbilical cord entanglement. The last and rarest type of twins is conjoined. This occurs when embryo division occurs more than 13 days after fertilization. Conjoined twins are connected to each other and may share organs. They share a single placenta and one amniotic sac. On ultrasound, you will only see a single placenta in a monodi or mono-mono pregnancy. There may be 1 or 2 gestational sacs depending on the timing of embryo split. If there are 2 gestational sacs, there's a very thin membrane between the twins, which is much thinner than what is seen in di-di or monodi twin pregnancies. The thickness of the membranes is easier to determine in the first trimester than later in pregnancy. Very rarely, the membrane is missing, which indicates a mono-mono twin pregnancy that is at high risk for complications. This is a typical image from a monodi twin pregnancy at 10 weeks. What can you see in this image? Please pause the video now to encourage responses. Here we have labeled 2 fetuses that each occupy a separate amniotic sac. Only a single placenta is visible. The dividing membrane appears quite thin. Later in pregnancy, the membrane is more difficult to see. Do you see the membrane in this image? Here we have labeled the membrane to make it more obvious. Here's another example of a monodi twin pregnancy with a very thin dividing membrane. This image is at 12 weeks. Notice that there is no membrane visible in the scan and that both fetuses share the same amniotic sac. This is a monochorionic, monoamniotic twin pregnancy, also called mono-mono twins. This is a scan taken later in the same pregnancy. Again, notice that there is no separating membrane between these twins. It is important to note the fetal lie of the twins as the time gets closer to delivery. Fetal lie refers to the orientation of the fetal spine in relation to the mother's spine and can be either longitudinal or transverse. A longitudinal lie can either refer to a fetus that is head down in cephalic presentation or head up in breech presentation. This was discussed in detail in the 12th video. If both twins are head down, we call the presentation cephalic-cephalic. If the lowest twin is cephalic and the other is breech, we call the presentation cephalic breech. If both twins are breech, we call the presentation breech-breech. The first word of the fetal presentation description for twins always refers to that of the lowest or presenting twin. The lowest or presenting twin is usually called twin A, and the other twin called twin B. Here we have labeled twin A and twin B in the illustrations. It is useful to have a system for naming the twins when performing ultrasound because certain ultrasound features or abnormalities might only refer to one specific twin. Any fetal presentation other than cephalic-cephalic is at higher risk at delivery. One or both twins can become obstructed or stuck. One or both twins may also have a transverse lie, as we see in this illustration. How would you refer to the fetal presentation in this case? We would call the fetal presentation breech transverse, remembering that the first term always refers to the presentation of twin A. Twins who share one placenta frequently share blood vessels in the placenta. This can result in more blood going to one twin than the other. This is called twin-to-twin transfusion. The fetal death rate in cases with twin-to-twin transfusion is high. In twin-to-twin transfusion, more blood goes to one fetus. Usually one twin becomes much larger than the other. This is a cross-section of the abdomens of twins with twin-to-twin transfusion. The larger twin is receiving more blood and has more amniotic fluid. Notice the marked difference in abdominal size and absence of separating membrane. Which type of twin pregnancy is this? The answer is monochorionic, monoamniotic twins, which lack a dividing fetal membrane. In this image, from a case of twin-to-twin transfusion, the smaller twin has no amniotic fluid, so it appears stuck along the anterior wall of the uterus. Here we have labeled the fetus's head and body to make it clearer. Beneath the twin, the anechoic fluid is actually amniotic fluid surrounding the larger twin. This is another example of a stuck twin from a case of twin-to-twin transfusion. In the left image, the upper twin appears stuck to the anterior uterine wall and has very little amniotic fluid, which is called oligohydramnios. You can just see an extremity of the lower twin, which is surrounded by too much amniotic fluid, called polyhydramnios. Here we have labeled these structures and the thin dividing membrane that can be seen in the right image. Now let's review key points. Which twins are at greatest risk of complications? Mono-mono twins that lack a dividing membrane are at a higher risk of fetal death. Twins that share a placenta are at higher risk of twin-to-twin transfusion. How should you manage a multiple gestation pregnancy? Always follow these pregnancies closely and refer for hospital delivery. A patient will come to your health center for a screening ultrasound at 20 weeks. If it is normal, she should return to your health center for a screening ultrasound at 32 to 36 weeks. If the patient has a multiple gestation, send her images to the referral hospital for confirmation. The obstetrician at the referral hospital will decide when the patient should come back for antenatal care and a repeat ultrasound. If a patient comes to your health center for the first screening ultrasound after 26 weeks and it is normal, you should encourage her to deliver at your health center. If the patient has a multiple gestation, send her to the referral hospital for a repeat ultrasound. The obstetrician will decide how to follow the patient and when it will be best to deliver her. Let's review the key points. Multiple gestation pregnancies are at higher risk than singleton pregnancies. It is easier to determine if there are separate amniotic sacs and placentas in early pregnancy. Complications of a multiple gestation pregnancy include preterm birth, low birth weight, obstructed labor, gestational diabetes, preeclampsia, and placental abruption. Review questions. What are the possible risks of a multiple gestation pregnancy? The answer is preterm birth, preeclampsia, low birth weight, fetal death, placental abruption, gestational diabetes, and obstructed labor. Which type of twins shares the same placenta? The answer is monozygotic twins that split 3 days after fertilization. What is twin-to-twin transfusion? The answer is a condition in which monozygotic twins share the same placental blood supply, and more blood goes to one of the twins than the other. At what gestational age should a woman with a multiple gestation pregnancy go to the hospital for delivery? The obstetrician will decide when the patient is to return for follow-up and delivery. It depends on the type of twin pregnancy and any complications. Thank you for your attention and interest in learning pregnancy ultrasound. Please pause this video now to ask your instructor any questions about this course. We thank the following individuals who played a major role in course development: Dr. Robert Nathan, Dr. William Marks, and Nicole Goldsmith, registered sonographer. Many other individuals contributed valuable time and expertise in the instructional design and materials development, including Dr. Christina Adams-Waldorf, Dr. Scott Barnhart, Dr. Michael Kawuya, Susan Kingston, and Stacy Lissett. Finally, we wish to thank Dr. William Marks for the use of images from his book, Ultrasound, A Practical Approach, and Jennifer Summers and Jan Hamanishi for graphic design and illustrations. The University of Washington Department of Radiology has trained healthcare workers in pregnancy ultrasound in many parts of the world. If you have questions about this video or course, please contact Dr. Robert Nathan, Dr. William Marks, or Dr. Christina Adams Waldorf. This course was collaboratively developed by the University of Washington Department of Radiology, Obstetrics and Gynecology, and the International Training and Education Center for Health, ITEC. It was made possible through a grant from the GE Foundation. Consano also contributed funding. We are grateful for the video production sponsored by the University of Washington Institute for Simulation and Interprofessional Studies. Please visit our website at tinyurl.com/UW ultrasound to access all of our training materials. This material is copyrighted. You are permitted to copy, distribute, and post to websites. You are permitted to modify the content to adapt to specific populations and user needs on the condition that you include attribution to the University of Washington and retain any copyright notices and citations and attributions included in the original Basic Obstetric Ultrasound Training for Midwives. The material in this video is provided for information purposes only. The University of Washington Institute for Simulation and Interprofessional Studies does not take responsibility for the accuracy of the content in this video.